Ladies and gentlemen, thank you all for coming here today on a Sunday evening after a long meeting, 3-day meeting. I'm very pleased to have every one of you here. It's a very big international group. We have colleagues mainly in our subspecialty, oculoplastics, but we also have dermatologists and plastic surgeons in the group. So it's a multidisciplinary group. I'm very happy to host this course, which is going to be run by a UCLA international faculty headed by Dr. Robert Goldberg. Probably most of you know Bob. Bob was kind enough to accept the invitation to come here, and he will share with us his tremendous experience about the minimal invasive rejuvenation of the periorbital area and the whole face overall. So what we will do is we will start with a small 5-minute lecture with Bob Goldberg, and then we will go to fillers and we'll do the injections and continue on with the botulinum toxin. So let's all welcome Bob in the podium. Okay, let me put this down. So where's your...
Thank you very much, George. Your time goes very fast, and it seems like you were just at UCLA as a little boy, as a fellow. Now, here you are, with this stunning practice in Athens and a reputation as the leader in our specialty here. So I'm very proud of you, and I'm very glad to be able to be a part of this course. As George said, we brought our group from UCLA. We run a 2-day course there every year. In fact, Danica, I think, has some brochures. George is often a featured speaker at that course, and Costas has been there many times. So I'm going to try to condense a 2-day course down to 5 minutes. But I just want to pick a few of the highlights of what we're going to talk about today in terms of facial rejuvenation. Traditional blepharoplasty focused on removing tissue. And technically, that's easy, right? Most of the people in the room studied surgery. We're very comfortable removing tissue. It's technically straightforward and predictable. Whereas adding volume can be more difficult technically. It's a little bit less predictable. And in some ways, it renders our surgical techniques obsolete. If you heard the last lecture today from Mo Hartstein, he was talking about the end of surgery. That's not going to happen. But the flip side of that is that when I look at results like this from our blepharoplasty courses, thanks. It's better not to take pictures of the patients, thanks. When I look at pictures from our blepharoplasty courses, this is a technically good result, but this result from the 1970s, I don't think anyone would see as aesthetically good now. And every day in my office, I see patients like this this is a lady who came in before blepharoplasty performed elsewhere, appropriately very unhappy with the change in her eyelid. She has a long eyelid, skeletonized appearance. And when you look at her top picture, I don't see why somebody wanted to remove volume from her. Her volume was pretty good to start with. And this is a typical result we still see in the literature of blepharoplasty result. But I don't think that's aesthetically a good result. The patient has lost too much volume. And in fact, as we age, we don't gain tissue, we lose tissue. The bone rotates and we lose bony volume from the midface and orbital rim. And in fact, when I think about my career, we really rethink the dogma of aesthetic orbital surgery so that you'll see today, instead of the upper eyelid becoming excess, we actually think of the eyebrow fat pad as losing volume, deflating, and the skin losing turgor. Instead of the lower eyelid fat and skin becoming excess, we see hollows and loss of elasticity, eyebrow fat pad, temporalis deflation. Also in the midface, we used to focus so much on gravity, but really you'll see today that we can accomplish a lot by focusing instead on volume in the midface. And in the muscles, people will go to meetings and talk about orbicularis hypertrophy, but our orbicularis doesn't grow, it doesn't get stronger as we get older. It loses strength, like all of our muscles. But the reason that the lines become more obvious is that the skin changes, right? The skin loses the ability to fight back against the muscle. And so in the last case today, you'll see how we apply neurotoxins to try to reshape and remodel the orbicularis and periocular muscles. Here's just some examples showing this principle of deflation. Here's a patient in youth and with age, and you can see she's lost volume from the upper and lower eyelid. And in fact, we lose volume in the superior sulcus and the inferior sulcus. Now, we might gain a little bit of volume in the fat. We did an MR study that showed we probably do gain a little bit of fatty volume, and there is probably still a role for blepharoplasty surgery. But most of aging is about this loss. It's loss of volume in the superficial and the deep fat pads. And you can see in this patient, look at the change in her eyebrow fat pad configuration where there's been deflation. She's lost volume in the superior orbit, and she's lost volume here along the orbital rim. So if we redefine the anatomy of aging and try to look at facial hollows, a patient like this who years ago I would have been in line with a bunch of other surgeons to see who could get to remove that orbital fat. But when I look at this patient now, I don't see that. I really see him as having an orbital rim hollow, which goes 360 degrees around the orbit, septal confluence, and the zygomatic hollow. We'll talk about these today. And so if we're going to take this paradigm of trying to address volume deflation, what are the options? Well, there's still a good role for fat injection. Before the hyaluronic acid fillers, I did a lot of fat injections. I do fewer now because I think the synthetic fillers are so easy, but there's still a role for fat, and we saw some good lectures in that today. Here's just some ultrasonography showing the survival of the fat in the subcutaneous tissues. This is work that Dr. Papagiorgio Costas has done. So the synthetic fillers are, I think, the workhorse for filling the periorbital hollows. We'll talk about them today. The trick is a very subtle filling technique. The periorbital area is delicate. The contours are delicate, and the skin is thin. So we have to have a very feathered, thoughtful, individualized technique. Everyone has a different facial configuration. But you can see this patient, I've demonstrated the zygomatic and orbital rim hollows being filled with a nice improvement in those contours. The same thing here, filling. So again, you might look and say, well, this is a fat pocket, but what I really see is a lot of volume loss in the midface and orbital rim. So we fill not just this tear trough area, but the entire orbital rim hollow, and also particularly in East Asian patients, there's loss of volume that starts to unveil the superior orbital rim. You can see she's had some nice improvement there as well. Another example, with 1 month, a good result. 4 months, he still has some result. 18 months later, he comes in for a second layer. And in the periorbital area, we've seen that the fillers can last for 1 or 2 years. Or Danica's getting ready to present a paper of the 13-year follow-up of Restylane in the periorbital area. Here's a patient with that long eyelid configuration that we were talking about. And you can see this is more of a septal confluence eyelid filling that we've been able to turn her from a long eyelid into a short, more aesthetically pleasing eyelid. Now, here's a 5-year follow-up, and you can see that there's some edema. And this is one of the things Danica has been studying. Over time, patients develop a little bit of orbital rim, I just can't get, there we go, a little bit of orbital rim fluid that develops, or malar edema, and that's something that we can pay attention to. It's a limitation for doing a lot of filling, and it's a good reason to try to be conservative. Here, on the other hand, is a 10-year follow-up with Restylane, and a 5-year follow-up here, showing really good longevity of the results with very little injection over time. And the last thing I'll mention is that the Charlie Brown hollow, we talked about the orbital rim. You know, the tear trough was named by Rob Flowers in Hawaii. It gets a lot of press and it's really caught on. But I don't like it personally because I think it keeps us from recognizing that the orbital rim hollow, as I said earlier, is a 270-degree hollow. And so, for example, patients like this with a deep lateral hollow can be addressed by filling the lateral part of the orbital rim. This is thin skin, and we have to be careful. But with the thinner fillers, we can get a good result. And Kostas, I think, will be able to demonstrate that a little bit today. Finally, we'll talk about lower face and mid-face filling. The mid-face is a very productive area for filling. And one of the things that we notice that as we re-inflate the mid-face, it lifts. And look at the improvement we get in the nasolabial fold. And in fact, I hardly ever inject directly in this area. I think it makes the lip too long. I think the malar area is best addressed by reinflating the volume. You can see that also in this patient. Look at the difference before and after filling in the contour of the cheek. You would have said, well, this cheek descended and we're going to lift it surgically. But there was no surgery here, just reinflation. And this, I think, supports our argument that mid-face aging is not just about descent. I think it's more about volume. And again, look at the improvement in the nasolabial fold and in the temple by reinflating that entire area. We talk about the forehead, and it's particularly, again, in the East Asian patient, flattening of the forehead is not only an aging change, but sometimes just a congenital, unpleasing age change. Alice Goh has written about this, and I hope she'll talk about that a little bit. And temple filling is very important. Skeletonization of the periorbital area is an important part of aging, and you can see the improvement we can get by filling not only the eyebrow fat pad and superior sulcus here, but also filling the temporalis muscle fossa. The same thing here in a young man. And lastly, a patient with the loss of volume and unveiling of the superior orbital rim that you can see, I think, well demonstrated here. I'm getting slowed down because I can't get the mouse, but that's okay. And you can see immediate result. And on the bottom, a 6-year follow-up. This young attorney, 2 layers of filling. And you can see the sustained rejuvenation of that upper orbital complex. So to summarize, we talked about loss of volume as an aging change. We talked about a paradigm of trying to reinflate these areas of lost volume to try to reshape the face. And we briefly talked about some of the specific anatomic areas, the superior sulcus, the orbital rim hollow over 360 degrees, the mid-face, and we'll talk as well a little bit today about the lower face and temple. So I hope that's a useful overview of the conceptual basis of what we're going to talk about today, and it'll introduce some of the specific concepts. So Dr. Coronis, I think we're ready to go with the next segment. While we're getting ready, are there any questions?
So we can start with... Well, thanks, Bob. So I think now it's time to have our first patient. Okay, we have Mrs. Paraskevi here. So, Mrs. Vula. So Vula is a 50-year-old lady that had a 4-lid blepharoplasty 6 months ago by a non-oculoplastic surgeon. And she's concerned with the hollowness and the appearance of the lower eyelids, where she has like a sunken type of lids, and the mild lower eyelid retraction. So I think, Bob, are you going to do this injection with Kostas? Okay.
You help us too? Yeah, no, you come up. You help me too. We'll have 2 assistants. So Kostas, you want to introduce some of the anatomic problems there?
Ποιος είναι, θα το δείξει.
Well, as George mentioned earlier, this lady is 5 months post.
Are you mic'd?
6 months after blepharoplasty, lower leg blepharoplasty, with a hollowness and lower eyelid retraction.
I guess we can talk together on mic, so I'll start. So let me see the picture on the screen. George, we should be looking at her face now.
Yes, let's see.
I'm going to have you put your head back. Just, is that comfortable for you?
You have to play with the... Costa, do you see the...
Yeah.
We have to fix the light. The light is too strong, I think.
Well, after this shit, they can fix that with the camera.
I think we're good now.
Good. Okay. Oh, I see. But we'll need more light for the treatment, so maybe we should just set the camera for better light. Who's running the camera?
There's more light.
Oh, I see. It's on automatic aperture.
Yeah.
How about if you do this?
No, that's okay. We'll do it like that. That'll work.
But we can have this in your side. Look. Are you starting from the left or the right?
I'll probably start from the left. As long as the audience can see it. Can everybody see pretty well now? That's not bad. I just want to get some good light to illuminate things. That's not bad. Okay, good. Thanks. So one of the things that we notice is a really deep orbital rim hollow here. It starts in the medial eyelid and then extends into what we call the Charlie Brown area here. And there's also a little bit of loss of volume within the eyelid itself. We talked about the septal confluence hollow. Between those hollows, she does have a little bit of residual orbital fat. Look down for me. Now look up. Can you see how the fat comes forward when she looks up? So this is the contour of the orbital fat. We're going to have to work around that. But I think that, and she'll still have a little bit of puffiness there, but I think we can improve it. Now the other thing that she has is a little bit of a malar mound here. This is often a result of allergy or fluid or a congenital change where the tissue between the orbital rim and the zygomatic hollow decompensates a little bit and picks up fluid. The reason it's important to notice that is because that can get worse after the filler treatment because the fillers are hydrophilic and they tend to bring in a little more edema. But one of the things that Costas and I talked about doing is maybe a little bit of a posterior girdle to try to get a little bit of that fluid pushed, flattened from behind, and we'll show that to you. So let me start on this. We can do it together, or I can start on this side.
30 gauge Volbella, so we can do
So this is a Volbella with a 30 gauge needle. I'll direct you. I want you to relax.
Okay.
Okay? They already have aromatherapy here. I noticed, Danica. Did you notice that when you walked in? I pay attention to those things now. My cotton tip applicator. When Costas was the fellow, he was the best tapper of his generation. But that was before Alice the Hammer Go showed up. Look up to the ceiling. So you can feel a little bit of a touch. You're doing so beautifully. Good. And the level that I'm at now is suborbicularis. And I'm injecting very, very slowly. Just a few microliters is all, maybe 20 or 40 microliters is all I'm going to try to put into this area. You don't need a lot of volume with the filler. Small amounts are much better than big amounts. You can always go back and add more layers. And it's rare for me to use a whole 1 cc syringe for one patient. A lot of times I have some left over even after doing both eyes, both sides. I personally don't like a cannula, but I think, Holly, you like cannulas. Are you going to use a cannula? Okay.
So you're
But-
suborbicularis.
So Steve, I'm suborbicularis, but above the rim. I don't try to touch the bone, but if I do, it doesn't bother me. It dulls the needle. But I would like everyone in the audience, people talk about all the tissue planes in the orbital rim. So do me a favor, take your finger and touch your orbital rim. And you tell me how much skin is in there. What's the thickness? What do you say, Steve? 2 or 3 millimeters, right? So there's not a lot of layers in there. And the orbicularis is the first 15 or 1800 microns. So I think when people talk about planes in that suborbicular space, I actually think they're imagining things. I don't think there's actually any plane that you can find. We're not good enough to find a plane within a 1,000 micron area. But it is important to be below the orbicularis because that allows us to minimize the bruising. By the way, whenever I see a tiny superficial bruise showing, either I or the assistant is prepared to put a little bit of pressure on there. So I've used 250 microliters so far, 0.025 milliliters. And I'm almost done with everything I want to do in this area. So I'm walking across. And then now let's move over towards the Charlie Brown area. I'm going to have you look at my finger now. Can you see the difference there? Right from between the sides? Look up again. Now the Charlie Brown area is, as I said, very difficult. For one thing, the zygomaticofacial artery is here, and the zygomaticofacial and zygomaticotemporal are in these two spots. Zygomaticofacial is particularly vulnerable. So I'm going to always try to imagine where that is. I'll try to come in just above it here. You're doing really nicely. You're such a good patient. I wish if you'd been my teacher, I would have probably got better grades. If you'd been my teacher, I would know my Greek history better. So I've done so far about 40 microliters in this area. I might try to get up to 50 or 60. I'm not even going to put a full tenth of a cc because it's such a delicate area, and a tiny bit goes a long way. I can't stress that enough. Isn't that what we've learned over the years, Danica? How little bits are so important, because you don't need to make a huge change. In fact, just a very subtle change is often exactly what the patient wants and needs. And getting greedy, either by the doctor or the patient, I believe more and more. I'm trying to give you all my 15-year experience. Getting greedy almost always leads to unhappiness here. Better to undertreat and do a little more. But look how nice she looks. Really pretty. You're going to like this a lot. It's really nice. It's really good. Should we try the other side? And then maybe, Costas, while you're doing that, I could do a little volume mid-facelift, okay? To save time.
The reason I asked that, Bob, is because a lot of guys teach the injection technique to go down, straight down to the bone and back up. I don't do that, I'm just saying.
So Steve, Dr. Leibowitz is saying that in a lot of courses they talk about going down to the bone, and it's like I just said. I think, look, it's not hard when you're looking at it to know you're below the orbicularis. I mean, everyone in this room has good enough three-dimensional sense to feel that they're just deep to the skin. And as I said earlier, I don't mind hitting the bone, but it sort of annoys me. I always wonder if it annoys the patient, and it dulls the needle. And so I don't try to touch the bone, but every now and then, I'll either feel I'm getting really close to it. You can just sort of feel the change in pressure as you get close to the periosteum, or I'll touch it a little bit. But it's not my intention to touch the bone.
Okay, so Bob, the key points here are very, very slow injection and go under the muscle. And try to avoid periosteum.
Slow injection under the muscle, small amounts, and a customized three-dimensional shape. Right? You saw how you're really trying to do sculpture, and everybody's going to get a different shape. I don't think you can do these injections by putting a big glob in and pushing it out. I see people do that. To me, you can't get that fine three-dimensional shape that you need. You have to really customize it. Was I withdrawing the plunger? That's a good question. I don't try to withdraw the plunger. The hyaluronic acid gels are so thick that it's very hard to pull them back out of a 30-gauge needle. And so you can do it if you spend a lot of time, but it's not really very practical. Plus the fact that when you do that, then you get air in the syringe, and air bubbles are very annoying. So I don't pull back, but I do inject very slowly. I was moving the needle all the time. And if you notice, we're not really near any of the big vessels, right? And what's the big vessel in the inferior orbit? It's the infraorbital artery. And that's below where we are. That exits a centimeter down on the rim. So I am always conscious of where that vessel is. We're not anywhere close to it here. Okay, do you have the voluma? Yeah, the voluma. So while Costas is working on the orbital rim hollow on the right side, we talked about, and by the way, if you look straight forward, before we do anything, is her orbital rim margin up a little bit there? I guess she didn't really have much scleral show to start with, but I think it's up a little bit. But certainly the eyelid, it has a much better shape now. So to work on the malar area, one of the points that I always like to make about the fillers is that we're trying to change the shadowing of the face. If I move this out just a little bit. Oh, you're such a good patient. So if I try to look at the three-dimensional shape of the cheek, her light reflex is down here now. And all I really want to do is move the light reflex up a little bit. I know I've been to voluma courses where they talk about mapping some particular point. I just don't teach that way, because to me it's really more like sculpture and art. I was so inspired by the Acropolis Museum. It must be in the Greek DNA to understand facial contours and structures. So I can't teach anybody here about that. But I do try to have a three-dimensional sense. Now with the voluma, I'm going to go down very close to the bone. Actually, I just touched it a little bit there, and I'm using a 27 gauge needle. Danica is giving her a little bit of tapping. Are you hanging in there okay? Is it all right? And going slowly and laying it into this point that I think is going to act as that posterior girdle for that malar fullness and give a nice little bit of submalar filling. Doing really beautifully there. And we can try to show the difference. Now I'm also going to try to work a little bit up, a little bit higher on the zygoma. You're doing okay? Feel all right? Really being a good patient. And this just to contour a little bit. This is a tiny amount here. That was 50 microliters, 0.05 mLs. You have to believe me, it doesn't take a lot. Now, as I look at the contour now, I still see a little bit of submalar hollow right here. And so I'm going to feather this a little bit right on this spot. And again, this is going to help with that malar fluid by making a little bit of a posterior girdle to push that out from behind. Now it's just 0.5. And so can we make the light to show the difference between the sides there? Is the light showing up all right to see the difference? Oh yeah, you can see it there. That's actually a nice view. So if you look at the picture, can you see what I was talking about in terms of the light reflex? See, we've just made that subtle contour on the treated side from the untreated side. And look at the lower eyelid, how much improvement there is in the contour. This is all it takes. You don't need to make a big change. A tiny improvement. It's not just that it's a small improvement, just a small change. Our eyes are very sensitive to little contours. And to me, this is going to be a fantastic result. You're really going to like it. It's really good. So Costas will get the mid-face on the other side there with the voluma.
I did a review already.
Okay. Does anybody have any other questions about the periorbital filling? Yeah.
Found that when you use injection on the orbital creator, you cut many times. Can you use just one injection
So I think that's a fantastic question. So the question is, I was using a technique where I made several punctures. Can you just do it with one injection? Do you do that? Do you do the cannula technique? I know Kathy Wong really likes it. So maybe Alice can we can have like the controversies at the course. I'll argue my side and she can argue her side. She's going to argue for one injection. So for me, when I look at these patients, I see a very complex contour that's different for every patient. And so what I'm trying to do in my mind is see the negative space, right? So I see the V-shaped negative space, and I'm trying to make a customized implant for that. And so I just find I can get a better result if I use the needle. In every case, I just heard you use a different pattern. Maybe it's partly just that I like, it's fun, it's more satisfying. But I really do feel like I can get a better contour. But I know some people will just squirt a big bit in there and push it around. I'm skeptical, but I'm open-minded. And Alice Go, is the most famous injector in all of Malaysia. So if she says something's true, I'm open-minded. So what do you think, Alice?
I think in my practice, I think patient selection is important.
Use the hot microphone.
You can use the microphone, Alice.
Patient selection is one of the key factors to determine whether you want to choose using sharps or cannula. Now, like in this case, if you can see, the periorbital hollow node is quite severe. Now, I agree with Dr. Goldberg when he actually pull in, volume. You can actually inject and immediately there's an elevation of the volume around that area. Now, in some cases where the hollow is just quite superficial, and cannula is just an easy way to go right underneath the orbicularis and deposit just a tiny bit of filler, and then you come out. Now, the other question is that there's always an argument about the trauma that you're causing as you enter with needles. Now, because cannula has this blunt tip, so you only put in a tiny one entry point, and then you can go maneuver around the whole entire periorbital area without any additional puncture marks. So the cannula is actually very friendly. As you go in, it's sort of go through the tissue quite nicely without damaging around the surrounding structures. So I think there's still role for needles, and in some people who have patients who are very high expectation, like you want to make sure that you don't give them any bruise or any injection marks, then a cannula would be a good option to do that.
It would have been good for our Hollywood actress last week who had 2 weeks of bruising. I just got texts from her again, by the way. You have to call her tonight.
Well, that was a really good job. And I think Holly's now going to talk a little bit about filler complications. And then we will move to the botuline topic.
Congratulations. It really looks good. Take care of your students, okay? Okay. I was going to comment on it, but it's not.
Okay, well, good evening, everybody. I usually give this talk with my good friend and research partner, Kathy Huang. She couldn't be here today. But, fillers have undoubtedly revolutionized aesthetic medicine as we know it. But like the saying goes, there's no such thing as a free lunch. So with fillers, there are also complications that we need to talk about. So the serious complications involve ischemia. Ischemic complications from filler injections have been reported everywhere on the face with every different type of filler. As far as how common it is, well, a retrospective review of over 14,000 injections showed an incidence of 0.05% for vascular compromise. That doesn't seem very high, but in the US alone last year, there were 2.4 million filler injections. So that means there were over 1,000 cases of vascular compromise. We don't know how many of those led to permanent problems, but it's a big enough number that it deserves our attention. And of course, the most devastating example of tissue ischemia is compromised blood flow to the eye area. That can cause ptosis, ophthalmoplegia, which is impaired movement of the eyeball, and of course, blindness. A literature review of the cases of filler-related eye complications in the last century showed 98 cases of eye complications. Most of those were published within the last 5 years. Each one of those little dots, good, shows where the injection was placed for each one of those eye complications. And you can see the glabella, the midline nasal bridge, and the nasolabial fold are high-risk areas. So now that we've gotten a scope of the problem, what is the mechanism of the vascular compromise associated with filler injections? Well, a couple of years ago, there was debate whether the mechanism was from external compression of a blood vessel or injecting inside a blood vessel. So I and my group at the University of Washington came up with an animal model to answer this question. Our animal is the immune-competent hairless mouse. So this is the mouse ear under the microscope. And you can see all the blood vessels. With our technique of optical microangiography, the ophthalmologists in the room will be familiar with this. It's a derivative of OCT technology. We use near-infrared light that bounces off individual flowing red blood cells to create a three-dimensional map of the vasculature. We can see all the way down to the capillary bed to a resolution of 5 microns. So first, we tried to compress the blood vessels. We injected a big bolus of filler, but OMAG showed us that the capillaries, the blood flow was continuing, even though the filler had remained a very tight bolus. So then we had to figure out a way to inject inside the arteries. The mouse ear arteries are very small. So we had to find a way to cut down to the external carotid artery. Once we were in there, we could inject dye reliably into the facial vasculature and the ear. And when we injected filler, we saw that the capillary bed was not receiving any blood flow, confirming that the mechanism for vascular ischemia from fillers is from injecting inside a blood vessel. Well, we think blindness happens the same way, from anastomoses or connections between the internal and external carotid circulation. So filler is injected superficially, it travels retrograde and then anterograde into the ophthalmic circulation. So the evidence that we have gives us a few suggestions for possible prevention of this complication. None of the preventions are foolproof, but we were just talking about aspiration before we inject. Well, that's really only effective with a very thin material like Sculptra. With the other fillers that are very viscous, it's hard to pull back, like Dr. Goldberg said, using a 30-gauge needle and get a flash of blood. So that's actually very hard to do. We do recommend limiting the total volume of product injected, injecting small volumes per needle pass, and not pushing hard on the plunger. You don't want, if you're meeting resistance, you don't want to push the product in. We do also recommend avoiding high-risk areas that have had surgery where the blood vessels can be tethered and easier to enter, or the anatomy is just not normal. And also danger zones. I know, especially in East Asia, the liquid rhinoplasty is very popular. Injecting into the glabella, the nasal bridge, temple, nasolabial fold, those are all higher risk areas. Either avoid them or at least have a conversation with the patient. And a lot of us have switched to blunt cannulas like Dr. Go was saying, to avoid entry into a blood vessel. But the reality is, if you inject enough, you'll see the complication. So it's our job to educate ourselves, our staff, and our patients on how to recognize the signs and symptoms of ischemia. Those signs and symptoms include whitening on injection, reticular pattern or modeling in a vascular distribution like we see on this photograph. Not everybody has pain when filler is injected intravascular, but if a patient does have pain and it's somebody that has had filler injections before and never had pain before, that's something to pay attention to. Later on, vesicles can develop, which have been mistaken for herpes infection. It's not. And when necrosis sets in, of course, it's too late. Vision loss from the case reports that we have occurs within minutes of injection, and usually with pain. So, and other immediate symptoms of orbital vascular occlusion include diaphoresis, nausea, headache, ptosis, and again, ophthalmoplegia. So how do we treat tissue ischemia from fillers? This is what a lot of people do. It's, you know, you see it, you get nervous, you just try and think of everything that you can possibly do to increase blood flow. So you'll notice a couple of these treatments is aimed at dilating the blood vessels to get more blood to the area that's ischemic. But if we remember our mouse experiments, if we are actually, if the mechanism is particles stuck inside the vasculature, dilating the blood vessels can push the particles deeper into the capillaries and cause further ischemia because the capillary bed is where oxygen exchange is happening. So Kathy Huang and the group at UCLA came up with an animal model, a rabbit ear model, to test treatment options. Because with the mouse, we can't test treatments because we're getting into the external carotid and the mouse don't survive long enough. But with the rabbit, what she did was to induce ischemia in the blood vessel by injecting filler and then applying topical nitro paste to cause vasodilation. What they found was the ears that were treated with nitro paste tended to become more purple, more bluish, more signs of vascular congestion. But ICG imaging showed that perfusion was actually not any better. In fact, perfusion was a little worse in the ears that were treated with nitro paste, which confirms our suspicion that if you dilate the vessels and push those particles deeper into the capillary bed, it actually doesn't help oxygenation. So what about hyaluronidase? De Lorenzi's study showed that ex vivo, outside of the body, hyaluronidase does actually penetrate through the blood vessel walls and dissolve the filler material. But we found when we injected hyaluronidase inside the blood vessel, we found quick resolution of the ischemia. The rabbit ear model confirmed that intra-arterial hyaluronidase can restore that perfusion. So our current protocol, and this is an important slide, is high-dose hyaluronidase, subcutaneous and intra-arterial. We also give patients aspirin, and we recommend hyperbaric oxygen if they have access to that. We prefer to treat patients within 12 hours, but we have had patients achieve full resolution even after 4 days of ischemia. Now notice, nitro paste is not on here. We do not recommend nitro paste for vasodilation. What about for blindness? Well, unfortunately, blindness from ophthalmic or central retinal artery occlusion, there is no treatment for. The preliminary data from the rabbit model shows that intravitreal injection of hyaluronidase and retrobulbar injection of hyaluronidase don't help. Intra-arterial hyaluronidase is very interesting, though. So this is Gary Duckweiler, neurointerventional radiologist at UCLA. He is part of that group that's studying treatments for filler-induced blindness. Borrowing from the stroke literature, where TPA is injected directly into the circulation for embolic strokes, Kathy convinced Dr. Duckweiler to cannulate the femoral artery of the rabbit and inject hyaluronidase directly into the ophthalmic artery. So this is what the rabbit retina looks like before occlusion. This is after occlusion with Restylane. And this is restoration of blood flow with intra-arterial hyaluronidase performed by the neurointerventional radiologists. And angiography confirms the same thing where you're seeing the, sorry, I'm looking for my mouse. You're seeing the restoration of blood flow with intra-arterial hyaluronidase. So in summary, we need to accept that complications happen. We have to educate ourselves, our patients, on the signs and symptoms and be prepared to handle the complications when they occur. Skin necrosis or blindness, although rare, can happen and should be part of the informed consent process with your patients. Again, this is the ischemic protocol that we use for tissue necrosis or tissue ischemia. We don't have a treatment yet for blindness, but someday there may be a stroke-like protocol involving neurointerventional radiology. Thank you. Okay.
Well, thank you, Holly. I think that was a very, very impressive. We rarely get the opportunity to hear such an advanced lecture on filler complications with a lot of science to back up your data. So now we will move to the next patient, and I think Kostas Papageorgiou is going to give us more information about the patient.
Can you hear me? Okay. Well, our next patient is a lady in her late 40s who is a good candidate for panfacial rejuvenation. By looking at her face, I think there are three elements that can draw our attention. First of all, she has left facial asymmetry. As you know, facial asymmetry is pretty common and is a key element in recognizing it before proceeding with volumizing agents and facial rejuvenation. The second striking element is the contour regularity along the lower eyelid mid-cheek junction. Although she hasn't lost significant volume on her mid-face compartments, both superficial and deep, you can see the orbital retaining ligament clearly demarcating the two contours. And this is further exacerbated by the fact that some laxity of the septum allows prolapsing of the infraorbital fat compartments. So we'll try to smoothen these contours with a little bit of low viscosity hyaluronic acid gel filler injections. And another key striking element is the loss of volume along the large lateral temporal fat compartment that leads to a little bit of ptosis on the lateral tail of the eyebrow. Although the brow foul span is relatively conserved, I think the loss of volume in the temples and of course the skin elasticity changes will benefit from some volumization of the temporal area. In addition, the loss of volume in the lateral fat compartment is leading to jowling, which camouflages the jawline. She has a good advantage. She has a good structural bony contour. So we'll try to further enhance the loss of volume in this area along the lateral jawline and also across the anterior borders of the jawline to further camouflage the jowling. If we have time, perhaps we could try to enhance a little bit the bony maxillary piriform fossa to further camouflage the nasolabial folds and ameliorate the appearance of the superficial nasolabial fat compartment. I think Dr. Goldberg can deal with the volumization of the upper third of the face, and then I will do a little bit of enhancement on the lateral zygomas and lower face.
It's okay. It's okay. Huh? Okay. Okay. We'll hear you. Yes. Yes.
So I want to point out something here that I think will be helpful. I can see the contour nicely, which is like we talked about aging of the eyebrow and upbrow complex, so that they do sort of these periods of just dramatic voices. She doesn't really have that much excess skin. A lot of this is just deflation. And so one of the things I'd like to do is, there, now I can hear myself. I'd like to recontour the upper orbital complex here. Open your eyes for a moment. As Danica pointed out in her lecture today, we're not focusing as much on the eyebrow hairs, but the three-dimensional contour. And when I look at her, can you see how there's some loss of volume around this area? She has pretty good volume of this part of the fat pad. So you'll feel a little bit of a touch here. A little tapping. Oh, you're a good patient. So I'm going to do just a little tiny bit of filling within the fat pad itself. Can you see that? By the way, this is not bad for a cannula. If I had a cannula, I could use it here and stripe it along. But I still, personally, I like the three-dimensional technique of a needle that I can really make a shape. Because now, can you see this contour up here that I want to change? A little bit of burning. This is under thin eyebrow skin, so I need to feather it carefully.
And all the fascial ligaments can be an obstruction to the cannula, so it's better with a needle, especially if they're
You need a microphone.
So Kostas, is this Volbella?
This is
Yes, we're using
Volbella.
Volbella on a 30-gauge needle.
So did everybody hear? It's Volbella on a 30-gauge needle.
Now, watch what happens here. As I get out, we don't have a good model of a skull, but if you look carefully, you can almost see her temporal line, which I imagine to myself comes along here, and then makes a turn along the zygoma, right? So once I get to this spot here, watch. There you go. I can get underneath the muscle. And there, Steve, I do go right down to the bone so that I can find the space, so I can get maximum protection from the muscle, and also maximum protection from any vessels, as Holly Channing pointed out. There's vessels, big vessels run in the muscle, but they don't run on the periosteum.
So please notice what Danica is doing right now.
And Danica's
to alleviate the pain.
Danica's doing some tapping. She has her pillow. Danica's been talking to her about
attention to detail.
things.
Yes, actually, it's the dentist do it. Dr. Smachlio says.
Really, really nice. Oh, you're gonna like this. It's really good. Wow, it's really pretty. It's fantastic. That light is unforgiving. It shows up in a little needle marks there, actually. But if you look at the contrast, can we see between the
tail of the eyebrow is higher.
So the tail of the eyebrow is a little bit higher, and the eyelid. We don't have her before picture. Look straight towards me. But that appearance of eyelid excess skin is actually substantially softened. I'm going to take one last little bit here. Work with me. I just want to get a little bit of projection of the eyebrow here. Now open your eyes. And look at the difference in the sulcus on both sides. I think you can see that pretty nicely.
Oh, we can see it really well.
Yeah. Now, in terms of her lower orbit, I would say her contours are pretty similar to the last patient, but she has a much more defined lateral orbital rim hollow here. Just for my own entertainment, I'll start there. And again, I'm suborbicularis, conscious of the zygomaticofacial artery, and trying to get just the smoothest three-dimensional shape
Bob,
That
can
was
you,
50 microliters there.
can you point us at the zygomatic artery where you think is in the
Well, if we had a
circle?
Doppler, we could find it, but it typically is pretty much at the 45-degree angle junction of the lateral orbital rim, and it's typically about a centimeter from the actual edge of the rim. So I would guess it's going to be right here, but it can be in a 1 centimeter circle. So to me, the danger area is a fingertip-shaped area right around here. So I'm going to try to avoid going directly through that area.
So
But
basically,
some days, George, it seems the best way to find it is just to put a needle in someplace, right?
Yeah.
Because it can be a little bit variable. But see, we should be well above it now, because I'm at the level of the orbital rim here. And we talked earlier about the infraorbital vessel. That's not going to be in our way when we do any orbital filling, because it's a whole centimeter down from the rim. So if this is her rim right here, the artery exit's going to be all the way down right about here. So we're not going to get in the way of that with any of the orbital filling. But for mid-phase filling, we do have to think about the infraorbital. And for lower phase, we have to think about the mental artery coming out of the mental foramen.
I want to add one more thing. When we are reinflating the SUV, the suborbicularis oculi fat compartment, there is a medial and a lateral sector. The lateral sector is very prone to malar edema, so it's very important to go quite deeply, almost coating the bone. If you go more superficially, there's a propensity of getting some malar edema. And always use small aliquots on that lateral part.
So those small amounts to me, you see how I'm sort of making three-dimensional shape? It's hard for me to do that with a bolus, because I'm really particular. And those are tiny little bits. That was 30 microliters, 20 microliters, less than 0.1 cc. And so if I just put a big bump in there and try to squish it around, I don't feel like in my hands that I can get quite the same three-dimensional contour. That's why that's the answer to your question. But I'd love to have Alice or someone do the other side, and we'll have a contest, double-blind experiment to see whether she could do the same thing with the bolus. Oh, you're really going to do it? Oh, good. We're going to have East versus West? I think that's actually really good. You know, I'd be interested to see that, Alice, the bolus technique. I would stop there. That was 0.8 cc's, which is actually a lot for me. But I think that... Let's see if we can get a picture of both sides before we do the other side so we can see the difference. Look up at the camera there. Let's zoom out. Let's get at the whole face.
Yeah.
There you go. So I think that's a nice example. Can you see how the orbital rim filling is good? But look at the difference in the eyebrow. You see how the tail of the left brow is up? And look at my finger here. Look right towards the camera. Good. Look at the difference in the sulcus from the right to the left side. I think that's a really nice result. I really don't think I would do anything else, right? Just soft.
And it's always important to stage the treatments. You don't need to achieve the perfect contour with the first session.
Right. Start. I would suggest you start with this type. So 0.8 cc is a subtle filling out. The temple takes more, and we could put a little more there. In fact, I'll just finish it. Well, no, or we can open some bloom also. Okay, do that with bloom. Alice, you can finish with this one. So Alice is going to show the idea of more of a bolus treatment. I'm going to finish up just a little more here. Can you work with me? A little sore. So I'm down below the muscle. You doing okay? Not too bad?
So here, Bob, you are deep. You're down to bone. Is that
I'm
correct?
on the bone, below them. I'm using the muscle. I'm trying to lift the muscle into the fossa. And George, one little trick is that you don't have to fill the whole temporalis fossa. The part that calls attention is the part of the hollowness that's next to the zygoma. So if you know, yes, if we had unlimited amount of medicine, we could fill the whole hollow and probably make an improvement. But if we just fill adjacent to the zygoma, that camouflages, it's the intersection of the muscle and the bone that shows up. So if we can efface that intersection, we accomplish a lot of the goal of the treatment. Even though she's a little hollow here still, that doesn't show up as much.
Is there any danger zone there?
Yeah, there are a number of large vessels that run through the temporalis muscle, both branches of the superficial branches and then some deep branches that come off the internal maxillary. And so, but they don't sit on the periosteum, which is why I like to be on the bone. They're within the muscle.
So that's a good point. You go deep, and there's less chance of getting a vascular accident.
The vessels don't actually lie on the periosteum. They're within the muscle. Okay, Alice.
So Alex is going to use a cannula, 27 gauge cannula.
Do you have enough light there?
So now we will see the use of a
Do you have enough
cannula.
light? Are you comfortable?
Yeah.
Okay, good. Oh, you're too little. Just a scoot to the side. That's perfect. You comfortable?
So, in a regular cannula, because the tip is blunt, so you need to have a sharp needle to give to introduce an entry point. So I'm using a 27 gauge cannula. So I'll use a slightly bigger size, slightly bigger bore needle, which is a 25 gauge.
So
Can you mic her?
Alice is using a 25 gauge needle to make the proper hole for the 27 gauge cannula to get in. If you can zoom in a little bit, we'll be able to see how the cannula is inserted. Thank you.
I can get through 30.
You can?
We give Alice the microphone, you think?
Yes, I think we should mic it.
So you can see the level. By just elevating the cannula, you can see that it's not that straight. It's actually underneath the auricularis muscle. So it's right here. So now you can see the tip. It's right at the medial corner. So you can slightly just very slowly
I guess we should ask the patient also which side feels worse, pain-wise.
So I've probably just deposited about 0.15 of rubella around the inferior orbital rim area.
Do you want to mention the mark where you can see
see.
the point?
Yeah.
When you
So-
were palpating at the beginning where you were going to put your cannula, how did you decide where you were putting your cannula?
Yeah, it's going to be underneath the muscle.
No, you are referring to the entry point.
Your entry point, how do you decide where that was?
How do you decide?
Oh, now it depends. If I were to treat even the lateral, the Charlie Brown, I will go slightly in the center so that I can, go medially and laterally with just single point. So the idea of using cannula is that you want to minimize, the entry points. So, okay, now, in this cannula, you can see there's a little, it's right here.
So I don't know if the camera can zoom in. You can see that dark arrow on the cannula. It points the exit of the cannula, the exit point. So ideally, you need to rotate this down so the filler is injected towards the lower structures of the face rather than upwards. So it's a little trick that can help.
We will ask the patient to see. So, Bob, what are you injecting now?
I'm injecting a tiny, tiny bit of voluma with a 30 gauge needle because I wanted to show Costas that it's possible.
So Dr. Goldberg is injecting with a 30 gauge voluma.
And it comes out very, very slowly. But I think that it's practical.
So
Very tiny injections, 20 or 30 microliters.
So it is possible to inject voluma via 30 gauge if you are patient enough.
But just tiny bits, very slow. But that's, in the eyelid area, that's what I like the best. Tiny bits, very slow.
Are you okay?
Mm-hmm. Yeah. Okay.
Are there any questions or comments from the audience? Please feel free to ask any questions you want. Yes.
So the posterior, you mentioned before that the tip of the cannula should be directed towards the posterior structures,
Yes.
not the anterior. Wouldn't the tip actually stand in the way of the filler? That if you want to see the result, if you just inject underneath the
No, the entry point, the exit point is not on the anterior axis, it's a little bit below. So ideally, you want the filler to go downwards rather than upwards.
Okay, that's what I wanted to clarify. So
Yeah.
you inject upwards, actually. So the filler is going anteriorly.
Well, it goes in a inferior 45 degrees angle, but on a downward direction rather than upwards.
Okay.
By the way, I don't want to burst your bubble on that, but in our ultrasound studies, the filler tracks back along the needle. It doesn't really follow the bevel, so I'm not positive that advice is evidence-based. But I don't see anything negative about it, but I'm not sure I believe it really works.
Well, it doesn't matter in the majority of the facial regions, but I think it's critical on the inferior area, especially in patients who are very hollow and you only have thin skin, orbicularis, and bone. So it helps better with the contour if the tip of the cannula is pointed downwards, the exit point of the filler is pointed downwards. That's from my personal experience, and that's the reason they have that arrow, actually, so you know exactly where is your exit point.
I've read that some other people use,
They use the tip upwards?
Yeah. So.
That's interesting. I've never come across it, but yeah, I guess at the end it depends on your personal experience and how you feel comfortable with.
I suggest you just not worry about your tickets. That's my personal bias.
Can't see.
So you can see now Al is filling with the cannula at the lateral SUF. I personally prefer to use a 30-gauge needle to fill the SUF. I still find the cannula a little bit traumatic within the submuscular layer. So we use the cannula on the medial infraorbital rim, and then for the lateral, just go straight with the needle over the bone and do some small bolus injections and then massage it. Maybe 0.1 cc's.
Do you want to do that? Yep. Just turn around here a little bit. You okay? Yeah. So you can see that with cannula, I only need just one entry point. I can actually direct to the medial, and then I'll make another entry point, a similar hole towards the lateral direction, and I can actually turn the direction of the cannula and fill up the lateral hollow as well. And I think she did check
Do volumization of the temple a little bit?
the temple. Do you want to do it?
No, it's okay. I'll do the lower face, or I can do.
Yeah. Okay.
Good.
Okay, good.
Okay, I think we have made 65 to 70% improvement of
Periorbital contours and the brow fat span. Ideally, expansion should be followed up in 46 weeks' time, and then do a little bit further layering. Now I'm going to do some volumization along the lateral diagroma, lateral and anterior jawline.
Estás muy-
The contours and shaving. We can change the microphone.
Yeah. Okay.
Can we change the, can we change the microphone, please? Sorry. Any other questions from the audience? Okay. Yes.
Do you massage it, then scalp it, and then spread it around?
I use a baby wipe usually. It's less traumatic. Okay, and now we're using again Voluma, high viscosity filler. I love it for deep structural bony sculpting.
For those of you that you do not, the Allergan products have a very interesting cross-linking technology for the product to work better. And it's a big improvement comparing to the ultra products that they had a year ago. Bob, do you have Vollift in the States, or you have Volbella? So in the United States, they have Volbella and Voluma. In Europe, we have Volbella, Voluma, and Vollift. Is that the same package or different package?
So what we're doing now, although she has a relatively good zygomatic projection, we're adding some volume deep over the zygoma against the periosteum, trying to reinflate the lateral fat compartment in order to ameliorate the contours on the anterior midface.
So Costas, what do you think of that here? What do you see?
Right, you can see the deflation of the lateral fat compartment. I don't like filling as much the actual lateral fat compartment in the first treatment session because it blends the definition of the zygoma. So I prefer to start by adding some volume deep on the zygoma, on the lateral part, to further give some lift on the deep medial fat compartments. Subsequently, I added a little bit of volume on the lateral jawline to further pull the jawline backwards. And then now I'll add a little bit of filler here, anterior to the jaw, to further camouflage and kind of enhance the definition of the jawline. Perhaps with a little bit of filler on her mid-chin.
What product are you using now, Costas?
Volume. So,
Voluma.
Yeah, volume.
To define the jawline.
To define the jawline and the zygoma.
And this balloon?
Sorry?
This is Voluma.
Yes. And you can see here, just by adding 0.2 cc of volume anterior to the jawline, you camouflage the jawline and her jawline becomes more linear and more defined.
Costas, I was pointing out also, in that view, you can really see the difference in the superior sulcus with the eyebrow, the change that makes. Really makes the eye just pop.
And also you can notice the light reflection difference between the left temple that has been volumized, even in a small fashion, versus the other part. We need one more volume. No? Do you want to do a little bit on the jawline? Yeah. Okay. So you can.
And then you can do the right side.
One more volume.
Are you using Voluma? Let me finish the other side.
Volbella? Yeah. So you take this. Okay, that's this, and then you need the 30 gauge?
Yes. So while Costas works on the left side, I'm just going to finish the sulcus and eyebrow on the right side to make it match, because it looks so nice and good. Wait till you see this. It's really good. You can't see it on TV. It looks beautiful.
So we see now Dr. Goldberg doing an inflation of the roof.
Right. And again, by the way, whenever I see a little bit of something that wants to make a bruise, I hold pressure. So, George, again, I'm not looking at the eyebrow hairs, but I'm just trying to sort of see a three-dimensional shape.
Of course, the neurovascular bundle is.
I aspirate always.
But how can you aspirate the volumen?
Is that volume okay, Bob?
No, this is the Volbella. I keep finding the best.
So around the eyes, we use Volbella because it absorbs less water, which is basically equivalent to Restylane.
Also, I inject preperiostally, so this gives me another layer of security.
And Costas, what contour are you trying to address down there?
Well, I'm trying to camouflage the jowling, basically, by filling the gap anterior to the jowls, by pulling them posteriorly and also adding a little bit of volume anterior.
Well, I notice we have experienced injectors in the audience, like Miss Olver from London. Jane, would you like to make a comment? Do you have anything to share your experience or? Sure. Costa, did you hear Jane's question? How many mLs we have used so far?
1 Volbella, and this is the second Voluma.
Okay.
So 2.5 cc so far.
2.5 cc.
1, yeah, 2, yeah, 3.5.
3.5 cc's of product.
Jane, I'm not sure what your experience is, Jane, but for me to use 2 cc's for the whole face actually feels like a lot. I rarely do more than that, and in Los Angeles at least, maybe like London, I see a lot of patients that have big volume. I just don't think it looks that good. I think it's distorted. I think the trick is to make very subtle changes in the lighting, but not change the shape of the face.
Plus, you also have to respect the barrier of the cost. I will never go beyond 3 cc's in one session. It's best to stage the treatment over a period of 2 or 3 sessions.
I agree entirely with Kostas on that, to do it in sessions. So do a little bit, especially if it's the first time that patient's having the filler from you, is just give them 1 ml maximum to begin with, and then get them back about 10 days later and add a bit more. That 10 days can be longer, could be perhaps as short as 5 days, and just build up their confidence and build up the filler very, very slowly so that you don't overdo, because that's the big risk, and losing the natural look.
That's a very good point.
Also, when the patient comes for the consultation, they don't have a specific idea of what are the overall facial changes. They might be concerned with a little bit of hollowness in the under eyes, a little bit of jowling, and then the consultation process kind of illuminates the whole aging process, yes, and a series of treatments that they were never considering so far. And this can be also a burden in terms of finances. So it's best to stage the approach, even over a period of a year, so you can accommodate all range of patients.
And you also want to undertreat because you want to allow the gel to expand. So when you treat 100%, then when the gel expands a little bit, then you'll be overtreated. So you always treat about 80% to allow the gel to expand And then once the gel expand, you see the patient back in 2 weeks, 10 days, 2 weeks, and then you reassess if there's any additional layering that is required.
By the way, Costas was talking about the expense of the treatment. I always think that periorbital treatments are much more difficult than the rest of the face. And when patients come to see me, it's because of my expertise in periorbital injections. So I charge $1,500 for eye treatment. And by the way, I don't care how many syringes I use. When I do a blepharoplasty, I don't charge for the number of sutures. So it's just, to me, they're paying for my expertise in the treatment. And I would like to see the tradition that eye injections are seen as a premium area. What do you do in London?
Charge, I don't know, $950. I guess it's on the high end, but
that's on the low end.
Sure.
For London, it's on the high end, I think.
It's too low for what the patient's getting.
True. But I'm pushing the barrier on the upper end. I cannot go further than that. But they understand that they pay for outcomes. So
this is a good take-home message, because we have to respect what we are doing. The periorbital area is a very difficult area to treat.
Absolutely.
And you have to be worth to treat.
Good. What I will add a little bit of, and now I'm just going to add a little bit of filler in her, on her chin.
The camera. That's perfect. Can we zoom out the camera, please?
Και αυτό θα σε πονέσει λίγο, έτσι.
Τι πρέπει να κάνεις?
Ναι,
So Costas is doing a piriform aperture injection.
This is slightly painful. I'm hitting the bone, aspirate, but it's a relatively safe and a vascular area.
As long as you're deep.
Yes.
And that's a good point. It's safe if you're on the bone, but the branches of the nasal artery
a little bit
come across the base of the ala, and we've seen alar necrosis from more superficial injections.
Yeah. I don't do superficial injection along the nasolabial folds. I prefer to enhance the zygoma and support from underneath by coating the bone.
This is a good one. Just a little bit.
All good.
Can you please hear? I don't hear Miss Olver.
On this patient, she's on her right side. She's got quite a deep trans cheek or nasojugal line, and I'm wondering whether the Bob and Kostas are going to be putting in more volume into the sort of upper cheek area shortly. Because I usually put a little bit of. I start with the upper cheek here, and then I put in the tear trough after that, because I find that provides a little bit of a scaffold, and then you need less in the tear trough area.
So you start from low and you start.
I start from low, give it a little bit of lift, and then use less in the tear trough. It's just a tip, but it's just a personal style.
Yes, perhaps you could have a little bit of filler here on the lateral orbitomalar groove, coating the maxilla.
Yeah, I do.
Do you want to do it, Dr. Goldberg, with a little bit of, you can use them.
The rouge should be perfect, so I put it deep.
Οπότε να κάνουμε, θέλετε να κάνουμε τα lecture.
Θα πάμε botox.
Πάμε botox.
Να κάνουμε την injection upper pressure
και όσο εγώ ετοιμάζω την ασθενή, θα δώσει η Ντάνικα το...
Jane, some of that line is just fluid from the injection. I don't think it's her natural cheek if you look at the other side.
Thank you.
But can you notice the jawline that now is well defined and blends better with the anterior chain?
Okay, George.
Okay. So I think now we should move to the botulinum toxin. Can I have my slides? Can you show the slides there? Okay, thank you. So let's talk about the use of neuromodulators in the upper face. And things have changed now. I will say some important points. First of all, do not freeze. Freeze is like a passé. Okay, we don't want the frozen face without any sort of movement. And you rather have to aim for a natural look that softens the wrinkles while maintaining facial expressivity. There's no cookbook approach, unfortunately. We have to individualize and tailor the doses and injection points on an individual basis. Why do we individualize? Because there are differences in anatomy. For example, we see this frontalis muscle here, the different types of muscles, so there are different injection patterns. There are different corrugators. And there's differences in muscle strength. And of course, there are differences in baseline asymmetries, as we can see this lady here. And obviously, gender differences. The male brow compared to the female brow are different. And we don't want to make a male brow look like a female. And we have to evaluate and explain. The patient has to know the difference between the dynamic and the static rhytids and the duration of the effect. Those are static. I don't think Botox will help a lot, whereas in dynamic, we get a decent, reasonable result. So we all know the classic applications for the glabella, the forehead, and the crow's feet. I'm not going to go in detail in those, but I'd rather talk about some other things in the upper face like brow asymmetry, microptosis, hypertrophic orbicularis, and bunny lines. Eyebrow asymmetry. We see this patient here. The brow on the left is lower, as you can see. And so those are all Botox units. Okay, I'm not talking about Dysport units. So the plan here is to elevate the left eyebrow and bring the right eyebrow a little bit lower. So you inject in the right frontalis, and then you inject the depressors of the brow on the left side to get a more symmetric result. Now, another point which is very, very important is the microptosis. Patients that do not have severe ptosis can be addressed with Botox. And I know most of you will say Botox for ptosis. Is he crazy? But, you know, the height of the eyelid is determined by the retractors and the protractors of the eyelid. So the orbicularis, what it does is it closes the lid, of course. So if we weaken the orbicularis by a tiny bit, then the eyelid will go, the eyelid height will change and the lid will go up. Of course, we do not treat the elevator. So in this patient here, we gave 3 units of Botox right above the eyelashes, and you see what the marked difference it made in the patient. Now, another point is the bunny lines. Some people have it more strong, and the nasalis muscles overreact and create these lines which are not very attractive. So if we inject the nasalis in several points, we can get a reasonable result. Now, orbicularis hypertrophy. You see these lines there? This is not fat. It can be addressed by injecting a tiny bit of Botox, 1 to 2 units, to get a result like this. So in summary, do not freeze, individualize, evaluate, and explain. Thank you. So as soon as Costas is done with his patient, we're going to bring another patient. Oh, yes. Okay, sure. So we'll have Alice. I'm sorry, Alice will finish the talk. I forgot. She's going to talk about lower face. And then we will do some botulinum injection.
Hello. All right, we shall continue with the afternoon session. Now I'm given a task of 5 minutes to try to summarize what are the areas that we can treat botulinum toxin in the lower face. I have no financial disclosures. Now, the face is actually the most dynamic area in the entire body. And as a result, all these wrinkles and lines form from the repetitive muscular actions. And as we know, most of the botulinum toxin indication were referred to the use in the upper face. And it is compared to the lower face, the uses of botulinum toxin is not as popular. However, there are some specific areas in the lower face that we can enhance with botulinum toxins. And these areas, some of these areas are actually best combined with some soft tissue fillers to achieve optimal results. Now, the key thing about using toxin in the face is the understanding of the function anatomy of the muscle in the face. And keeping in mind that there are a lot of variations between patients. So that, like what Dr. Sharonis was mentioning, that all these treatments should be individualized, and then learning the muscles in the face, and that we should target specific muscles to inject, and then we want to aim to achieve a dynamic balance of the face. Now, some of the aging areas in the lower face are what you can see here, but I will only speak on the perioral wrinkles, the downturning of the corner of the mouth, and also neck bands. We also see in even younger individuals, there are hypertrophic muscles around the lower part of the face, for example, the masseter. And in some individual, where there are contraction of the elevators that exposes a lot of their gums, as you see in the gummy smiles, and maybe a little bit on the dimpled chin. So the perioral lines are, due to hypertrophy of the orbicularis muscles, and this one, is accentuated with aging, and also in patients who are smokers. That's why it's called also termed as smoker lines. Now, what we can do is, we can actually have patients to pucker their lips and then identify where the dynamic wrinkles are, and you can place 1 to 2 units of botulinum toxin just above the vermilion border. The next is the downturning of the mouth. It is not usually done independently. Most of the time, you can actually, add in a little bit of soft fillers to, increase a bit of volume over the myriad lines to improve the volume loss. But you can add on a little bit of some botulinum toxin to sort of relax the depressor anguli oris to sort of elevate the cornea of the mouth so that it doesn't look very, depressed and downturned. That makes the patient looks a little bit more, sad and depressed. So what I've done is that, you can actually place about, 2 units of botulinum toxins around the lower part of the depressor angular oris. Now, from this picture, you can see this is before the injection, and after, you can actually see there is some improvement, and any additional volume loss, you can actually, combine it with some soft tissue fillers. The next thing we want to talk about is the platysma. And with age, you can see that, some of these bands develop, and you can also treat with botulinum toxin. Now, you can have patients to show their lower teeth, and that excess skin, the folds that would fall forward, and then you can actually, place a little bit of botulinum toxins along the band, and it will relax the muscle and give, So what you can do is that, as you said, have patients to clench the teeth lower, and that will show. And as you can hold the band and then just inject superficially along the bands. I think we will probably demonstrate later one of the patients. The other issue that some of the patients we have is the excessive exposure of the gums, and if that in the literature, if the exposure is actually more than 3 millimeters, some of these patients want to have treatment done. And most of the muscle that is responsible for this is actually the levator labii superioris aliquot. So you can place a small, about 1 to 2 units around this area to lower down or to relax the muscle. And the last part we can talk is the dimpling of the chin. This is not very common, but sometimes patients do present with, and they do not like some of the dimpling around this area. And you know that this is the action of the mentalis muscle, and you can place some 1 to 2 units around the 2 bellies of the mentalis. And last but not least, we, in Asia, in East Asia, is a very common thing that, and the masseter is relatively larger, and that gives, the Asian a very square face. And a lot of these young girls who come and request, because they want a V-shaped face, which is very popular. So what we can do is that we can, have the patient clench and then palpate the borders, the anterior border and the posterior border of the masseter, and then you can, inject a little bit of the botulinum toxin. I typically like to feel the contracture of the muscle and then place my initial injection at the area that is maximum, and then I can go around and place more toxins. And before that, this is just a tip, you do not want to go above. So what I do is that I can actually draw an imaginary line from the lateral corner of the mouth to the mid-tragus, and that I would make sure that I have to stay below this line, because anything above that, you might inject into the zygomatic muscles, and it may cause asymmetry of the angle of the mouth. So you can see, it's very, very effective. Just one session, but usually because the masseter muscle is a bulky muscle, it takes up to two weeks to show some results. And in some of these patients, we actually encourage them to come back every 6 monthly to have repeat injection, because repeated injections will actually, have a longer term and longer effects of reshaping their face. So in summary, as when I first started, sometimes you get a bit nervous on where to place, but if you really know the anatomy well, then you can really place the toxins very specifically in the area that you want to inject. So, and because, toxins, there's no antidote like fillers, it's always good to start conservatively, and then you have patient come back. If it's necessary, you can always top up the toxin. Thank you.
So let's move now to the injection part. I'm going to do the upper face, and then Alice is going to do the lower face. So this nice lady here, her brows are a bit low. Can we have the camera, please? Okay. Can everybody see? Okay, can you look straight ahead here? Κοιτάξτε εδώ. So the brows are a little bit low, and they're more like T-shaped. So what I will try to do is chemically lift the eyebrows, creating a more C-shaped approach. So what I will plan to do is inject the corrugators and the brow depressors here. I will give one injection in the middle of the brow here, and also I will inject the lateral portion of the orbicularis, so that after a few days, the eyebrow will go into a more feminine and physiologic height. So what I have done, those are pretty basic things, and I think most of you know what we do is we have taken 2.5 cc's, okay, of normal saline, which makes, if you look at here, I like to use this type of syringe here. So every 0.1 cc is 4 units. So we have already sterilized a little bit with some alcohol swabs the skin of the face, and then you ask the patient to frown. Κάνετε μια συνοφρίωση. Κάντε έτσι, συνοφρίωση. Okay? This is to assess the strength of the muscle and also the type of the corrugator. Okay, okay, you can relax now. I like to put my non-dominant finger at the level, and I go all the way down and inject 4 units. And I do the same thing on the other side. Okay, and now I have the patient. Okay, now another point that I like to make is on the upper part of the corrugator, I inject more superficially, because in the anatomy, the upper head of the corrugator goes more superficially towards the dermis. Okay. And then what I do is I inject 2 units in the middle part of the eyebrow. And 2 units in the other. And that was 20 units total. So moving on now. Is it Lexi? Okay. We go now to the tail of the eyebrow. So I like to inject 4 units here and 2 units underneath. Maybe close enough. Okay. Four units and 2. And now we can move towards the crow's feet. In the crow's feet, I like to inject very superficially. And what I do is I put my finger across the lateral orbital rim so that the needle doesn't go past the rim. The light is a little... I inject 2 units here, 4 units here, and 2 units here. Alimia. Punto. Is this a toxin? Two units, 4 units, 2 units. Okay, and I think we're done with the upper face, and now Alice will do the
Neck bands, right?
Let me give you the neck bands. And if you can please show us how you assess the neck band so that can somebody help me with the, what is the,
Do you want Brazilian muscular?
No, I think she wants the neck bands. This one. And the muscle is the other patient.
4 units per 0.1.
Can you sit up?
So in some points I injected 4 units, in other points I injected 2 units.
Okay, no, I'm doing the...
Most of the times I use Botox, but occasionally I use Dysport. I use a lot of Dysport in Cyprus because I have it more available there. I don't think there's a huge difference. So now, Alice, can you tell us, please, how you assess the platysma bands and how you're going to treat them?
So the platysma is the superficial muscles, from the chest, it actually moves forward and then goes up to the lower part of the face, and also some attachment to the corner of the mouth. So if you have patient to actually clench and show your lower teeth, you will show the bands of the platysma. Can you show? Can you do this? No, not very much. Show me again. So here, not very prominent, but you can actually see, the anterior bands falling forward. In some severe cases, you can also notice that the posterior band will show up around this area as well. Okay, show me again. Okay. It's not very much, so we can just give very little. Okay, let's see. So platysma is a superficial muscle, then you don't have to go very deep, just very superficially.
Can you have the volume up a little bit for Dr. Go? Because we're going to hear you.
Okay, so say come. Can you all see just the very tiny bands over the anterior border over here?
Alice, are you using the same dilution, 2.5 cc's?
Yes.
Yes, okay.
So these are just very tiny bands. So essentially, you can just place about 1 to 2 units, and along the bands of the neck bands, and the distance between about 1 centimeter to 1.5 centimeter. Say, show me again. So we're using the same dilution of, so I'm giving about 0.2 here. Say E again. Yeah, I'm using 2 units.
How far do you space the injection?
About 1 centimeter to 1.5. Okay.
So 2 units per injection, 1.5 centimeters spread apart.
Last part. E again. So I won't do very much because she doesn't show a lot of the bend, so I'll just treat it. Look down again. Say E again. I'm trying to see if she has on the right side. Sorry. So all treatment should be individualized because everybody will have different anatomy. So in her case, there is no bends on the right side. There's no need to chase. And for now, we are just treating the left part of the anterior bends, and I think that's sufficient. And probably you can go on to the next patient who wanted to do the masseter. George, do we have the patient that wants the masseter?
Yes, this lady here. So, are
Yeah.
you done? Okay, so then let's see a masseter treatment now by Dr. Go. So usually, as Dr. Go said, the masseter is a nice application for the lower face with little complications, and it's especially suited because in some people, if the masseter has hypertrophy, the face is more of a square appearance, and by treating the masseter, you make the face more of a triangle. Especially in women, this is attractive. So,
Actually draw an imaginary line from the corner of the mouth to the mid-tragus, and this is the area that you want to stay below this area. And now you have the patient to clench their teeth. Can you bite?
Can you bite?
Yeah, you can. You can actually palpate, the anterior border of the masseter, which is right here. Relax, and bite again, and over here. Okay, relax. Okay, bite again. Now I can feel this point is the maximum contraction of the masseter muscle, and this is going to be my initial injection. And then maybe 1 centimeter ahead of it, and so this is going to be where I'm going to place my botulinum toxin. So like for her case, relax and bite. I would say this is a moderate, I will probably just place about 20 units on each side. So a total of 40 units for both the masseter.
Personally, I don't exceed 20 or 25 units per side, even in patients who have significant hypertrophy of the masseter. I get a lot of referrals of patients who had masseter reshaping and they develop localized hypertrophy. And this happens when you use 2 or 3 entry points and larger doses. So I think it's best if you stage the dose over a period of 2 to 3 months because it's also functional muscle, which is very important for the mastication.
So I've actually placed in deep because the masseter muscle actually has 2 bellies, the superficial and the deep. So you actually go deep. Bite again. Okay. Relax.
And the major complication of this treatment, I think, is diffusion of the toxin anteriorly. You can get diffusion to the labialis muscle and the pressor anguli oris, and can be a pretty annoying complication. So it's best to stay safe and do lower doses, multiple entry points, microbolus injections, staged over a period of 2 months.
0.5.
Alex, is there an anatomic order? Can you ever feel the labial depressors and actually see them or palpate them?
Sorry?
Costas was talking about trying to avoid the labial depressors.
Well, diffusion of the toxin.
But this area is just mainly the bulk of the muscle, so you are actually quite safe to go deep into the muscle. The only thing that you may have to be careful is sometimes the cervical or the mandibular brush or the facial nerve may come across here, and if you actually do inject into the nerve, patient will actually feel a bit of a tingling, electric sort of sensation. So patient will you make sure that you have patient to alert you. So we have done the right side. I'm going to go ahead and do the left.
Another complication to consider is a potential risk of fistula of the parotid stent. It has been reported. It's very rare, but it can happen.
Sure. Okay, bite again. Yeah.
You can turn your
Turn
head a
it.
little.
So once again, relax. Okay, clench. So you can actually very clearly demarcate and feel the anterior border of the masseter. Bite again. Yeah, which is right here. Okay, relax and bite. If you actually see, if the camera would come closer, you can actually see the contraction of the masseter muscle. So right here, you can even, feel that the anterior border, this area you want to avoid as well, because this is where the facial artery, actually crosses on the anterior border of the masseter. So I'm going to go ahead. Okay, relax. Okay. About a centimeter ahead, anterior to that. Bite again. Sorry. Okay. Okay, relax. So, you felt what?
Yeah, it's okay.
A little bit. Yeah, the injections a little bit. Okay.
Talking about injection depth, there are three muscles in the face that you inject deep. One is the corrugator, the other is the masseter, and the third is the mentalis.
Yeah.
The very superficial one is you go the crow's feet, and all the others are in between. So, are we done, Costas, or?
Yeah.
Okay, so our next presenter, I'm proud to present Danica Fiaschetti, who is the senior aesthetic coordinator at the Jules Stein Eye Institute. I had the chance to meet Danica 20 years ago when she was at kindergarten there. So she's going to give a whole different perspective now to the course, and we're all ready to hear your talk.
Thank you, George.
Can we have Danica's slides, please?
Okay. Thank you. So I'm going to talk about the patient experience. Is it the result or the patient experience? So I put this slide up here because we all traveled here on the plane, and we all had either a good experience in traveling or a bad experience. If we look at the pilot as our doctor and the flight attendants as our staff, we all need to work together as a team. And one thing that's unpleasant in the whole experience can throw off the whole experience. Having a bad flight, lost luggage, all these things work together. So is it the result or the experience that the patients come back to the office? Okay. I had a slide there, but it's gone. We did a big study on hyaluronic acids, and we know that they last for a very, very long time, for years, even up to 10 years. And when we were looking at our data, we noticed that the patients would come back to the office even though they didn't need filling. And so we took all that same data that we had and we went back and we looked at the reason for the visit. And we had all these patients, we looked at the return visit, the reason, and what we found was that the patients returned to the office 1.5 times a year. But most patients didn't receive any injections. So if they didn't receive any injections, why were they coming back? And at least 90% of the patients at one time in their follow-ups didn't receive any injections. So we were very curious, why were they coming back? The patients came back because they had a perception that they lost the filler in the lower eyelid. But interestingly, many of the patients just wanted to know, am I looking okay? Is the filler still holding up? Now, these are sophisticated, educated patients, and they can look in the mirror and see what's going on, but they really wanted, and what we thought was that they were either subconsciously or consciously seeking validation about their appearance. We're in Los Angeles, maybe it's a little bit different. We have a different kind of cosmetic patient. So they all came back to the office because they seemed to enjoy the visit with the staff and the doctor. They seemed to leave the office uplifted. But in most cases, patients weren't disappointed to be told that they don't need another injection. But we did have some of our patients that felt even abandoned if we said that they don't need an injection for 1 or 2 years. Dr. Goldberg would leave the room and the patient would stand in the office and look at me and just say, he doesn't want to inject me and he doesn't want to see me for 1 or 2 years. It's almost like not being asked to dance at a party. And so the patients would stand in the room and I would say, okay, well, you can come back in maybe 3 months, 6 months, but maybe we won't do any injections. They also felt rejected. So there's a lot of psychology with the cosmetic patients that we had to deal with. But the bottom line, injections are scary. Now, our office is 50% functional and 50% cosmetic. And out of that cosmetic portion, 90% of our patients come in for lower eyelid filling. And as Dr. Goldberg said, we charge $1,500 for a lower eyelid filling. That's an awful lot of money. And so we're at a university, we're competing with the fancy Beverly Hills offices. Patients have to come, they have to park. It's a little bit more difficult for them to get here. So we need to make their patient experience wonderful. So how do we do that? What do we do? What do we do differently? The patient experience is everything. We use Zen techniques. We have a great outcome. Thank you, Dr. Goldberg. We have friendly staff. We have compassion for the patients. And we have a good office energy. When the patient comes to the office, they're the center of attention. It's almost like when you go to the hairdresser, the barber, you go to get your nails done. You're sitting there and it's your time with the doctor. You talk about intimate things. You begin to trust the doctor. When Dr. Goldberg and I are in the room, I'm tapping, but we're conversing back and forth. We're talking with the patients. We ask them about their family. We know what's going on. We spend that whole 30 minutes with them. So we're actually doing psychotherapy. So it's an experience for them. And sometimes we're not even injecting them, but they leave and they walk out uplifted. We were lucky enough to partner with the Urban Zen Foundation at UCLA. And this was a foundation set up by Donna Karan, the designer. And her husband was dying of lung cancer. And it was his dying wish to train doctors and nurses how to do Zen therapies. So these Zen therapies are aromatherapy, Reiki, meditation, and yoga. So I was trained, and these were things that we were able to incorporate with our patients during injections and maybe in-office surgery. We published a little article on reducing pain and anxiety in periorbital injections. And some of the things we use in the office, we use a pillow. If you noticed, I didn't have a pillow tonight, and I placed a blanket. Anything that you can place over the lower half of the patient makes them feel more secure. They feel vulnerable and exposed when you're coming at them with needles. If you remember, you're all ophthalmologists, and when you go to see a patient and you need to use the slit lamp, most women keep their purse on their lap, and then you have to ask them to move it, then you place the slit lamp. So it's all about feeling secure. We use aromatherapy in the office. That helps the staff and the patients. We have great music, very zen music playing, and our tapping distraction. So the pillow placement is the easiest thing you can do. I just put this right on the lap of everyone, the men, the women. They don't even ask, you just simply place that over them. Lavender oil. The use of essential oils became around in World War II, had a revitalization, and it has a lot of calming and emotional balance. There was a study done with cosmetic procedures, lower heart rate and blood pressure with the use of lavender. And so usually I'll just put a few drops on my hand and let the patient inhale that before some of their injections if they feel a little anxiety. There's also this study on the vibration anesthesia. We don't like the device, but we use a tapping technique. So here we are. So in conclusion, bonding with the staff, the patients return to the office for the relationship. The patients feel listened and feeling understood. And it's the positive reinforcement that the patients want about their appearance. And of course, absolutely the effectiveness of the treatment. And thank you so much. So I brought my little lavender if y'all want to, try a little bit, carry it around with me. So.
Well, thank you, Danica. You see the level of expertise and finesse that they have at UCLA, attention to the detail. So now we're going to move to the last part of the course, which has to do with threads. And Kostas is going to introduce the threads and the patient.
I have no financial disclosures with this type of treatment. Over the last decade, we have witnessed an increased demand of non-invasive rejuvenating treatments as the baby boomer generation continues to age, and also newer generations find some form of societal acceptance for these interventions. It is not surprising that the latest line of Yves Saint Laurent skincare team was inspired by the so-called Technic eye generation, referring to those who tend to check their smartphones and tabs more than 150 times per day. Of course, surgery has more powerful and longer-lasting results, but not all patients present with extensive aging changes. And of course, concerns with regards to risk, cost, and recovery time can force patients to opt for the less and more often approach. In addition, beauty editorials and journalists and bloggers tend to glorify the latest non-surgical. And this influences the patient's mentality. So if there's a way for them to avoid a surgical procedure and address the latest non-surgical, they will simply go for it, especially patients in their late 30s, 40s, or early 50s who have busy lifestyle schedules and like to enhance their facial features with no downtime and no days from work. So there has been a philosophy shift with regards to the patient's perspective, but also I think the surgeons and the physician's perspective. And myself belonging to the younger generation of surgeons, I think I have a different threshold of whom I will list for a surgical procedure, comparing to someone who is 15 or 20 years my senior. As a result of this philosophy shift, a wide range of energy-based and non-invasive anti-aging treatments have been established as an alternative armamentarium to non-invasive facial reshaping. Hence the popularity of therapy, for example, that uses the power of ultrasound to target the deeper muscle layers, the SMAS, but also the deeper dermis, and induce a relatively discrete regenerative effect, but with no pain and no downtime. But how do we address deflation or volumetric changes of the fat compartment situated both superficially and deep when the energy-based devices and the volumizing agents are not powerful enough or they can no longer be effective? The silhouette soft threads are a new generation of threads and can be a valid alternative for non-surgical lifting. They have been available in Europe for almost 4 years now, and last year they were granted FDA approval, so they're currently available also in the USA. The unique advantage of these threads is the lack of invasiveness. They're able to achieve a dual effect, lifting action and regenerative effect without the need of skin incisions and deeper fixations. So who's the ideal patient? The ideal patient is a patient, perhaps I would say in their early 40s, who are concerned with a little bit of submental laxity as well as laxity along the jawline. Of course, the concept of facial threads and barbed sutures is not new. But what is new with this new generation of threads is the fact that the technique is minimally invasive. And as I mentioned earlier, it doesn't involve any incision, deeper fixations, and the recovery time is relatively short. The procedure can be performed with a little bit of topical anesthetic cream and some minor injection of local anesthetic on the main entry and exit points. It takes approximately 30 to 45 minutes. Of course, it will depend on the amount of facial laxity if you are addressing only the jowls or also the neck area. And of course, the time frame is related to the number of threads that you're using. The treatment involves an entry point with an 18-gauge needle that goes 3 to 5 millimeters within the dermis. And then the 2 needles of the thread are inserted in a sequential manner and in 2 opposite directions, targeting the target areas in different vectors that we're going to discuss later. So you can see here now the thread, which is made from different cones, and it is these cones that tend to engage the target tissues and provide also deeper fixation. The cones are available. The threads are available with a different number of cones. You can have either 8 on each side, so 4 on each side, so 8 in total, or 6 on each side, so 12, and also 8 on each side, so 16. Personally, I prefer the 4 cones on each side because they have a shorter length, and I think I can get a better draping of the target areas. Now you can see here the different techniques and patterns of application of the threads. You have the linear technique, the L technique, which is great, I think, for definition of the jawline and addressing the jowls. The red dot stands for the entry point, while the blue dot refers to the exit points of the needle. So for someone who is interested in addressing the jowl area, like our patient, I will personally favor a combination of the linear technique with the L technique. Also, the U technique has been described. I don't think it's very effective because, as you can see, both areas of the thread and the cones are running in parallel directions, and the fixation point on the lateral area of the face doesn't have any cones to engage and support and provide support. You can also do combined techniques. It's a little bit more complicated, I think, the combined technique. Again, you can also address the neck. And the linear technique, I think, is the more suitable. And although the threads are meant to run along the deeper dermis, I personally favor a deeper plane. So you can have at least one part of the thread engaging deeper fascial layers, either this being the temporal fascia or the parotid or the posterior auricular fascia if you're addressing the neck. The threads are made from polyallyl lactic acid, which is a biodegradable and fully absorbable material. PLA has been widely used in the medical field, from vascular stents, orthopedic medicine, biostimulatory fillers like Sculptra. So the key point of this biostimulation is not as much the regeneration of collagen, but rather the fact that this local reaction creates some areas of healing response, and it's this healing response that is going to maintain the lifting effect long term once the cones and the threads have been absorbed. I'm just going to share a couple of cases. This is a lady in the early 70s. She has significant volume deflation and skin elasticity changes. She didn't want any volumizing agents. I thought she would be a good candidate to improve her marionette lines and jowl area. So you can see her here a few weeks after the application of the linear and L pattern along the jawline and mid-face. Another lady here, a few weeks after a combined approach on the lower face. The main concern of this lady was the excessive laxity of skin in the submental area following an aggressive liposuction. So you can notice here by lifting the lower face and SMAS, and just with one linear thread on the neck, you can make a decent improvement on the neck area, assuming that this is a non-invasive and non-surgical approach. And then we went back a few months later. This is the result, and then I added a couple of more threads on the neck to further improve the contour. Who is the non-ideal patient? I think a patient that has a relatively heavy face with a lot of fat, square jawline is really hard to resist the volumetric shifts of the fat compartments and obtain a good result. The only reason I offer her the treatment is because she didn't have to pay for it. Was kind of a friend of mine, but I wasn't happy with the outcome. Although the company, the manufacturer company, actually the threads are made in the USA, although they became available at the beginning in Europe. They state that the treatment can last from 18 to 24 months. My experience shows that perhaps it's 8 to 9 months. I would place them in the same duration with the volumizing agents like Voluma. Of course, there will be patients that will fall outside this time frame, either longer or shorter, depending on the individual features and aging changes. There is some bruise and edema because you're inserting a 23 gauge long needle along the face. And there is some potential risk of damage to neurovascular structures. Another limitation of the treatment is that the patient, for the first 2 weeks, has to be very careful with facial expressions and animation, because you don't want the cones who have been so meticulously positioned to dislocate before they start creating some biostimulatory response, so they're well held in place. They even have to pay attention to how they sleep at night. There might be a little bit of skin puckering immediately post-treatment, and this might be necessary to optimize the lifting effect, but if this happens, it tends to settle within a couple of days. So in summary, I think that as physicians, we have to always be alert and embrace all the innovations in the aesthetic industry, but in the same time, we have to use our judgment and experience and logic to try to select the treatments that can really benefit our patients. I think this treatment can have a valid role in a select group of patients with moderate degrees of laxity. I usually tend to combine this treatment with the therapy. So I will firstly do the therapy to target the deeper foundation of the skin, and then after a few weeks, I will go with the silhouette soft lift. Another potential useful application, I think, especially in the oculoplastic field, is using the threads to try to create some enhancement and lifting of the tone and position of the lower eyelid in Bell's palsy or paralytic cases, where whilst you're waiting for the patient to recover in the initial months, you can use in a minimally invasive fashion this thread to support the lower eyelid. So the key point with this treatment, I think, is the threshold. Having a very high threshold to whom we are offering this treatment in order to have happy and satisfied patients. And finally, what I would like to add is, if you're going to offer to a patient a treatment that has a short duration of effect, in that case, it has to be minimally invasive at all, with no incisions, no scarring. Because I think there is a lot of commercial marketing of the short scar facelift and all these other procedures that are not powerful enough, and they're not long-lasting, and patients, you know, are being dragged from the advertisements of the mirror of the aesthetic clinic. So at least this treatment doesn't involve any incision, doesn't cause any scarring. So unless you have any questions, we can move to the practical section. Yes. How do I manage? Well, it's a semi-sterile procedure. I would say it's 75% sterile.
But in the event you develop an infection, what
well,
would you
I
do?
try to disinfect as much as I can. It's an office procedure, but there haven't been reported any cases of infection. It's the same concept as using a biostimulatory filler like Sculptra. You're not 100% sterile, and you're using a 25 gauge needle. Of course, you're trying to maximize the sterility, but by rule, it can be 100% sterile. But it's not a surgical procedure, so you only have an entry point with an 18 gauge needle, and that's it. The vectors go back. So it works like a string in two directions. So you pull downwards, you readjust, you pull kind of the cones engaging the fat compartments, and then you go upwards and you further readjust. So you work in two directions, and you gradually trying to balance the tension. So it's, you know, you have to reach a fine point where you can reach the maximal effect without causing too much puckering or contour changes. No, you pull the inferior downwards, and you pull also the superior upwards, but you hold the tissue, so it goes in two directions. So the thread goes up, and you pull the tissue downward, so the cones can engage the tissues.
So you pull from the red and from the blue?
Yes, so no, the red is the entry point, the blue is the exit point. So if I go back to okay, so this is my entry point here. So first I will go with one needle down, and then all the way, I will come up, and then from the same entry point, paying attention to not create any loops that can go this way, and then go from this way. Yeah, so let's say this is the jowl area. So I will pull the thread like this, and then I will push the jowl upwards. Then move to the temporal fascia. I will pull the string upwards and move the mid-face downwards. Then I will go back. You have to do a lot of back and forth. It can take you even 10 minutes just trying to optimize. And since you're using two threads, you have to adjust gradually the pulling and the lifting action along the two threads. You can't optimize to maximum tension the first thread, because then you'll find that it might not be ideal when you have the second thread. Yeah. Yep.
If necessary, how can you remove it?
You cannot remove it. You cannot remove it. And theoretically, it can break. It never happened. I mean, if it breaks, it's fine. You can just leave it there. It can cause a little bit of biostimulation, maybe a little bit of lifting. No.
What about the secondary fibrosis?
Secondary fibrosis?
Fibrosis. Reaction on threads.
Yes, I mean, they're meant to cause some healing reaction, some fibrosis, and this is how they're meant to maintain their holding action, lifting effect long term, because the cones, the PLA, is going to dissolve within a few weeks' time. But the fibrotic reaction is meant to maintain the lifting.
I mean on
You mean a nodule or a
overreaction? No.
No, no. Of course, you have to make sure when you insert it that you are in the right plane, not too deep, not too superficial. Yes. No. There are a lot of physicians who use in the brow. I personally think that in the brow cannot be forgiving. You have a dynamic area, the frontalis muscle, and the eyebrow is an arced, has an arched shape. So also foreheads in patients over 45 are relatively devolumized. It's a thin area, like 3 millimeters. So I wouldn't feel comfortable inserting the thread in the brow area. I will volumize the temples, do chemodenervation, volumize the brow fat pad, or dual therapy, but not the thread. So I think it's more forgiving, and you can achieve, a better result. Yeah.
So let's proceed with the treatment now. Το φως λίγο.
Okay. I usually tend to start from the right face. It's just my random personal choice. I think it's going to work better because we have the light on this side, so it's better to sit with better lighting. So the reason we have selected this patient is because she has some early signs of jowling and of course some mid-face deflation. So we'd like to enhance a little bit the jaw definition and also give her some more projection, the zygoma, and lateral mid-face. Do you have any sterile drapes? Any drapes?
Yes, I have.
Okay, and I need one more.
Clear?
Yeah, we can open them. One second.
Okay. You have one more, yeah, the drape. Also one more pair of gloves. 7, 6.5.
I like the leather, right? Really,
You can put just one.
Okay, thanks.
And do we have a sterile marker pen?
No, sterile, no.
No. Okay, I'm gonna change gloves. I'm
Okay.
just gonna use the white pencil. And we'll need a couple of more. Okay, Mr. Daxon. So I'm going to do some initial markings. So this is my target area, the jowl area. And I usually measure 4.5 to 5 centimeters between the entry point and the exit area. Okay. As you can see here, these are my two entry points. And this is the linear pattern with my exit point and exit point. And again, this is my entry point so this is the linear application and this is the L-shaped application along the jawline. Again, my exit point is going to be on the lower side of the jaw area.
Let's mark them at the same time so you get smack it. I'll let you do the marking just because it's best to have one person mark. This is our fellow UCLA Wenjing Liu, our senior fellow. I was saying I don't like to try to do anything without her helping.
What are you measuring there?
I'm measuring the distance between my entry and exit point.
So I'm saying, how are you picking it?
It has to be over 4.5 millimeters, centimeters. Of course, this works as a general guidance during the treatment. You can bypass the exit points. The entry point is the critical. Okay, we're going to inject a little bit of anesthetic now. Gauge needles, please. 18 needle. Okay, thank you. This is the anesthetic? Yes.
What's the Botox?
Oh, okay. Oh, the anesthetic is here. Okay, great. It's fine. Oh, he's already doing that, so it's fine.
Okay. This one?
Okay. Thank you. And do we have another pair of gloves? We can have a few more in the house. Okay. Just a little bit. It's mainly the entry point. You don't want to distort a lot with the
and I can have a little bit of sterilizing solution here. Un po' di qui. All okay? Do you have any questions with regards to the marking or the vectors? No? Okay.
How much do the threads cost?
It's £1,000 for a box of 10. So they come in pairs of 2. Every box has one more glove. Sorry, but every box has 5 pairs. Okay, I would, yeah, don't open there too there, so it's fine. We can leave this for a moment. Sorry, my hands. Okay. So this is the thread. I'm just going to place it close to the camera. This is the needle. Perhaps here. So maybe it's a little bit zoomed out. So it's important to stretch the thread and make it as much leaner as you can. Okay. So, attach.
See, like a nick opening.
Okay, so now I'm using an 18-gauge needle to make the entry point down to 5 millimeters from within the dermis. So I go down, and then I try to create a little bit of space going upwards and a little bit of space going downwards. And this is very important as it facilitates the insertion of the thread into directions.
And avoids a dermal pucker.
Absolutely.
Okay. Does that feel okay? Not too bad?
Can we have the light a little bit on this area? The light. If you can switch it on and target this area here. Switch it on from there. Good. And turn it this way. That's better. If you're not happy with the entry point, it's critical to go back and really enlarge that entry point. So I'm not very happy with my entry point. I'm going to go back with a needle. No, we're good.
do you want you guys for lunch on this side? Just make sure they're nicely open. She's feeling good. Tiny bit more now.
Okay. So the thread at the very end has a dark spot, and that indicates that you are within a dark line, a black line, that indicates that within 5 millimeters in the dermis. So you go vertically, then you turn maybe 45 degrees, and you start advancing the needle, trying to follow the pattern, the placement. Are you okay?
Mm-hmm. And Costas, why don't you describe what level you're trying to pass the needle?
So now I'm in the deeper dermis.
So you're trying to you're trying
Correct.
to engage the deep dermis. So you're not as far down as the subcutaneous fat.
No, I try to stay
Within
in the deeper layers of the dermis.
Because the prongs work by engaging the dermis. So you want to try to skirt in the deep dermis. How can you tell if you're too superficial?
Well, you can kind of feel it.
So you don't want to have the thread palpable.
Thanks. So now I'm trying to advance the cones within the entry point. Okay, you can feel it going through the tissues. You have to be very gentle and do a little bit of massaging of the overlying dermis to help advancing the cones through. And now I'm going to use the other end with the same entry point and go upwards. Do you want to do the other side?
Oh, let's do it until I see.
Oh, yeah. The entry point is the most critical part of the treatment. Is the toxin? So going upwards towards the temporal area can be a little bit uncomfortable.
Wouldn't they be more comfortable with the zygomatic facial block? A little sting, a little sting.
Okay, so now it's very important here to make sure that there is no misalignment of the loop when you insert the second part of the thread. Okay, here we go. So the thread is in place. I'm pretty happy with the depth. I cannot feel it. It's all aligned. And I will do just a little bit of pulling in two opposite directions. And you can feel the cones advancing. Is the toxin?
Costas, how do you know, can you describe how to feel the point of optimal tightness?
There's how hard do you have to pull to strip the cones?
Well, you cannot pull that hard because then you'll start seeing the cones coming out from your exit point.
Well, that's pretty far.
Not really. I mean, my cones now are up to here. Yes, but of course you work in combination with the second thread. So now I did a little bit of partial tightening. I'm not going to do any more on this thread, but I will do the final adjustment once I have entered the second thread with the L pattern. Do you want to do the linear on the other side?
Yeah.
Can I have some more antiseptic? Yeah. Yeah, antiseptic. Can I have some antiseptic here? Antiseptic. Just put it there. Perfect.
It's like what's the nurse's name?
Okay.
Hunter, we need a circulator. Can you help us with the light?
Maybe with the iPhone. Yeah, I'm good with my light. That's fine.
That's good. That was good right there. A little up. Where you at? Good. A little down there. Good.
That's the best.
I'll get lower because you're in a better position to get the other.
So down.
I don't want to dent the skin.
Elena. Ένα ψαλίδι θέλω. Sterile. Αλλά εντάξει, πώς θα το κόψεις, you can cut it. Just cut it and proceed. Cut this. And you can cut this too?
Smart hand techniques for field playing. Oh, I'm sorry. Almost done. Does it feel? A little more superficial. You want to be. I'd like to see the pin tap in the drums a little bit. That's it.
Is the action?
There. There you go. George? Oh, am I the moderator? Hey, Steve, could you moderate any questions?
So do we have any questions down here? Speak up. Why did it take so long? Why did it take so long? Yeah. You think it's a long time for a lift? We heard. Yes. He said it stays 8 to 10 months in his experience. Right, Costas?
Yes.
That's a good question. Can you repeat the procedure, Costas?
If Not after 9 months, no. But of course, you combine it, as I said, with other treatments. You add volumizing agents to further enhance the jawline, or perhaps you dual therapy. So, and then I leave it also to the patient to decide.
He's doing the second, the L now, right? So we heard how much the threads cost. We didn't hear how much you charge.
I charge £2,500 per 4 threads. So 600 pounds per thread.
£500, so that's like $3,300. Well, how much pain does the patient have both now and tomorrow?
The pain is intra-procedural. There's no pain after the procedure.
Any other questions about that? Don't be shy.
Seems like we caught a little bit of dermis. So Costas, we caught a little bit of dermis in the cast. Is there a way to unwind that?
Yeah, we can go with the needle.
With the needle.
A little bit, or a cannula.
Yeah, cannula, because I don't want to hurt the thread.
Sinon.
You got the video on this? Are we looking over here? So, on this side, I've caught a little bit of dermis. See that? I've caught a little bit of dermis in the needle. So I'm going to release that just with a little bit of subcision. Nice. That word looks worse than it is because of the light. Because I feel like I'm in a nice spot on both sides.
Okay.
That should be good. Okay, you want to tighten it up there, arranging.
Helena?
Pull on it, push the skin up so you feel it.
Είστε εντάξει, τώρα πονάτε, αλλά πρέπει να σας δώσουμε λίγο ibuprofen.
Use two feel it out like this. You'll feel it up. That's nice. I should look at that. Mom's up to the first bar up there, so that's good. You can see the lift.
Για κάθεστε κόψτε αυτό. Και αυτό.
They want to cut it flush. Don't we cut it flush, or do you cut the needle
Not
off
yet.
first?
Once you have optimized, then you cut it flush. No, longer, as long as you want. Okay. And once you have happy, then.
I can't get that dermal pucker out. I'll give that a try.
So.
Yeah, we got a nice hit.
On this side.
Yes. So as you can see, it requires a lot of manipulation back and forth, further optimizing the tension. The puckering will go down anyway. Okay, I will stop here. Κάτι σήκωσε.
That's the second one.
You're not convinced? Huh?
These tracks, it's so visible.
No, they go down. Actually, I went deeper one day.
Bring it a little bit.
Ωραία, είμαι εντάξει από εδώ. You can put, why don't you put a glove to fill it? Put a glove to fill it. Do you want to put a glove?
I had a good entry to classes. They just don't want to go.
Where? This is the. You can still. Oh, I see. Well, where's the? Oh, you. Okay.
Let me try something for a second. I'm gonna just.
No, don't put the other one.
This over the cones.
Okay. So you pull back and now you can
That's
go.
because Costas works out. I've been to the gym to get this project. Okay, so I'm right on this. There should be no thermal capture. If there's any thermal capture, there's no justice there.
Τα έχουμε τελειώσει σχεδόν. 2 minutes. Τελειώσε.
I thought I had one entry hole there. That was the best one ever made. I really worked with that entry hole. I wanted to just make entry hole with 11 blade.
Cut.
Να κόψουμε, Έλενα. Έλενα. Sorry.
Oh, those poor Westcott scissors, it breaks my heart.
They're
Cut the 4 open.
And my Westcott scissors, you know?
really.
That one's better.
Let me just play a little bit. No, no, no.
Yeah, that's it. I don't think any more lectures, Stuart, just questions. I don't like the journal.
It's just gonna settle down. Let me. Yeah, it will settle down.
It releases from the dermis.
Yeah. I mean, you get a little bit of puckering because you maximize the tension anyway.
Right.
And you expect a little bit of release because the patient will animate, you know, laugh. So. It's better. I will stop here. Can I have the scissors? I'll get it. Can you please stand up for a second? Scoffitally. She's nice.
So, let's take a look. Can we see with the camera?
Ωραία, ναι. Όχι, δεν. Είναι και το facial asymmetry.
Ναι, το φίλο μου αυτό είναι.
Όχι, δεν θα της κάνω άλλο
Γιατί η
tightening.
γωνία στο σωστό παραδείγμα το
So when you cut, you pull, and then you cut. Ωραία είναι. It's nice.
Yeah.
Κοιτάζει.
Pretty expensive. Yeah, the internet. It's cheap.
What do you think, Rob?
But that looks good.
Yeah, it looks good, right?
That's nice. So,
You
so
can
can
see-
the audience see the change of the contour now? Put the chin in just a bit. That's it. Good. It's nice, Costas.
Yeah, I think it's good.
It's really good. That looks great.
So it's always a fine balance between how much you're gonna pull, how you're gonna optimize the jawline. I think it's okay. You tend to overcorrect a little bit by 15%. If you go more than that, you're gonna get more puckering, and patients don't like that. And after a few weeks' time, we can just go back with volumizing agents and further enhance the jawline. Yeah, I mean, you can come to dinner, no one will know. I mean, she can go out and leave the office. It's not. Ωραία. Το πάνω. Would you?
Costas, do you have a solution for the
saggy?
This, yes, you can do it for, yes, I think, but it will work only when they have skin laxity, not a lot of submental.
Two on each side?
Yeah, two, you can, yeah, I think two per side. You can go 3, and then it becomes maybe a little bit more expensive, you know?
Oh, yeah.
And then,
Do you think, I played a lot with the barbed sutures.
yeah, the permanent ones, or the dissolvable.
Permanent, but they have thick barbs like over here. And I quit because they don't last long. I mean, the effect is pretty good in the beginning, and after a while it starts sagging. So do you think, this is a better option?
I don't know. This is my first experience with the threads. As I said, I wouldn't place them 18 to 24 months as they stayed. I would say between 8 to 10, 11 months. So, you have to find the right patient who is willing to...
Barbed ones go like, 6 to 8 months.
6 to 8. So they work like the PDO threads, right? The barbed.
They're, thick ones.
But they're not bidirectional.
No.
The nice thing about that is this is bidirectional.
This might be a better option.
Yes.
So, thank you everybody for coming to this course. I don't know, I think we all learned a lot of things today. And I hope we will have the chance to do this in the future one day. And we will improve more. But thank you for coming.